I'd like to talk now about alternate methods of insulin administration. We've been pretty much talking about one-time injections. A person may administer those to themselves, or we as nurses administer insulin and even oral anti-diabetic medications to our patients based on their sliding scales as far as insulin injections go. But sometimes our patients may come in with an insulin pump, or maybe we may get them started on that before they leave the hospital, if we feel that they're competent enough to be able to manage an insulin pump, because it can be a little bit more of a convenience for some of our patients who are diagnosed with diabetes, but they really have to have the knowledge and the instructions and understand how their pump functions so they do not develop any complications. Because if that pump does not deliver the insulin, these patients can run into some very serious problems, such as DKA, where the pump is not providing the insulin, especially after one eats, and does not kind of get a sense as to how many carbs a person is eating in regards to how much insulin should be delivered to the patient. But the types of pumps that are out there now are very, very sophisticated and really keep the patient's blood glucose rather in a very safe range. It just is important that the person realize that the pump is functioning properly, and that the parameters for potential alarms would definitely kind of be activated if a person's blood sugar goes too high or goes too low. So it could kind of alert the person that, hey, something just is not right with this particular blood glucose level. So when we talk about alternate methods of insulin administration, continuous subcutaneous infusions are what you're probably most familiar with. And with this particular type of insulin administration, it does allow the person more flexibility in meal timing, because if a meal is skipped, the insulin is not given. And usually within these pumps, they use the rapid acting insulins, and they adjust the amounts of insulin received based on the data from the blood glucose monitoring. Okay, but as with any type of delivery system, problems can happen, and obviously, because it's an invasive type of monitoring where there's a needle in the subcutaneous tissues, things like skin infections can occur. It's necessary that the person changes their needles every 2 to 3 days. They can be more prone to hyperglycemia or ketoacidosis or a DKA type of situation if the pump is not functioning correctly, or the pump is not filled to provide the insulin that is so needed, especially after mealtime. So it does require the person to have intensive education, and if blood glucose levels still continue over 300 milligrams per deciliter, it is necessary that the person have the knowledge to check for ketones, because obviously there needs some major adjustments in insulin delivery because the blood glucoses are just too high. Some of these pumps can be quite costly because of their sophistication and really over-the-top technology that comes with some of these pumps. There's also some of the new technology out there are the insulin pens in which insulin is loaded into a pen-like holder, and there is a disposable needle that is attached to the device for insulin injections. And what the person has to learn how to do is to kind of feel comfortable with the equipment. It's delivered by dialing a dose or pushing a button for every 1 to 2 units increments of insulin that's going to be delivered. It's very convenient for people who need to inject only one type of insulin at a time. Maybe they're eating out a lot, maybe they're traveling, or maybe they do have some impaired dexterity and also have some vision and cognitive dysfunction, due to the fact that they've had diabetes for a long time and they're starting to develop a lot of these neuropathies. There's also jet injectors, which are injection devices that can be needleless, absorbed at a faster rate, shorter duration of action. These are very, very expensive. I'm not sure all hospitalizations will cover the expense of this. And with the needleless devices, they're replaced by an ultra-thin liquid stream of insulin that's forced through the skin under very, very high pressure. And it's important to know that if your patients are administering insulin in pre-filled syringes, they really need to be stored correctly, upright usually, so that the insulin doesn't clog the needles. And I think I've said that before. The pre-filled do give, greater accuracy, but at times as different from the insulin pens, you need to make sure that you can see those little increments very closely. So people with vision problems maybe would not do so well with that. As I said before, with these liquid stream of insulin, where it's given, through the skin under high pressure, it's not uncommon to see some bruising at the skin because the force of that stream is really, really given under a fair amount of pressure. I also put up here too about glycogen, and we can administer glycogen in the hospital, and I think most of our acute care settings do have standing orders for glycogen. And I'll be honest with you, in all my years of nursing, if my patients were severely hypoglycemic, I've never administered glycogen in the hospital. Why? I'm not saying it's not effective, but it's the amount of time it takes to be effective. It can take up to 20 minutes before the patient may start to respond. And to me, that would be very stressful as a nurse to watch that patient still remain so obtundant due to the fact that they're so hypoglycemic. And I guess I just feel that it would not be the best means of trying to get that blood glucose up as quickly as possible. That's why most of us in the hospital administer the 50% dextrose, which can be a little bit difficult. It's in a very wide, large syringe. Obviously, it's given IV push, and the person must have a really, really good IV, okay? So that's why I always encourage nurses to make sure that if the patient does have a IV in, even if it's not connected to fluids, that it's being properly cared for. We are following hospital policy as in regards to how often that site should be changed. So if they are diabetic and they would need this 50% glucose, you surely want to give that to someone that has a very durable and viable IV site, because otherwise you're going to push that under very high pressure and it's going to blow the vein, and then you're not going to be able to give that medication unless you have a good IV. So I can't stress the importance of that, and as students, and hopefully when you graduate from nursing school, that you'll definitely implement the policies of proper IV therapy to prevent not only complications, but also to have that IV readily available in case emergency IV medications need to be given. And with the rise in so many of our patients being diabetic, you always want to be prepared for the worst. And many times, because of the vulnerability of our patients who are in the hospital because of some kind of illness, we know that their blood sugars can be very labile and all over the place due to the treatments that we give them. So it's always a potential situation for these patients to become hypoglycemic. And I'm telling you, your 50% dextrose probably is your best way to go if you're a nurse in the hospital and you want to get that blood glucose up very quickly. Now, glycogen injections are given to our patients on a homegoing prescription, okay? And it's very important, particularly if family are aware of how to give that. Obviously, they're not going to have an IV at home most of the time, so they need to learn how to give it sub-Q or IM. So it's always good to teach these patients as well as the families on proper administration of an injection. So if by some chance they come to the person's home and find them unconscious, the first thing you want to do is, administer this, because it's a probable cause is hypoglycemia. But the only thing is, you need to let them know that this does not work very quickly. It takes about 20 minutes. So some people don't really have a lot of patience for that, may call emergency type services to implement treatment for these patients. But you'll need to let them know that this is a good way to bring up blood sugar, but it's not one of the quickest ways. So I just wanted to definitely let you know about my experiences. Maybe some of you that are LPNs, that have worked in nursing homes, that administer medications, may give this much more frequently than I sure have given in the past. So I just wanted to kind of talk to you about that. As I said with these insulin pumps, it's basically an external device. It acts like a pancreas. It inserts a needle or a catheter in the subcutaneous tissue, usually around in the abdomen, and we usually secure that with tape. But the thing is, these needles have to be changed every 3 days. It's usually administered at a basal rate of about 0.5 to 2 units per hour. And after a meal, a dose of insulin is calculated based on the amount of carbohydrate that's ingested. Usually, it's set to deliver 1 unit of insulin for every 15 grams of carbohydrates. When these are working great, it's wonderful for our patients, okay, because they don't have to give that repeated injections to themselves. And really, it can monitor blood glucose levels, so you're not checking an AccuCheck all the time like you would, or the way we do when we're in the hospital with our patients. But the disadvantage to these insulin pumps are an unexpected disruption in the flow of insulin can cause your patient's blood glucose to rise very quickly for things like if the insulin runs out, or if the battery is depleted where it doesn't really register the blood glucose or actually deliver the insulin that it's supposed to based on carbohydrate intake. Then your patient now is at risk for DKA. There can also be infections at the needle site, so those insertions of needles must be done under very, very aseptic technique. And sometimes it can be an inconvenience to wear pumps. But you can also disconnect it if a person wants to shower, exercise, swim, or even for sex, so that pump will not be in the way, and then there's less chance of it pulling on that needle and dislodging that needle. And if by some chance the device is not working, that person really needs to have an alternate means to be able to administer their insulin, have syringes at home, maybe an AccuCheck machine, because maybe they develop an infection. Well, obviously we're going to have to pull the needle out and probably not allow the patient to use this means of insulin delivery. So we have to go back to the original ways. But as I said before, the patient himself must have adequate knowledge when having a pump and really be in a constant communication of an endocrinologist or dietitian or an educator. They only use rapid-acting insulin, and the common risk is obviously ketoacidosis. Most of the insurances will cover the cost of pumps. Some of these pumps can go as high as $1,200, $2,500, just depend on the sophistication of the pump and exactly what it does. But it's always important to know that if some complication or malfunctioning of the pump occurs, that the person has the education and the knowledge to be able to remember to inject themselves or know how to inject themselves with syringes and have that equipment available for a backup. Okay? Just wanted to just encourage people when they travel. With insulin, always carry it with you when flying. If you're going to check your bags, and make sure you don't have all that equipment in a bag, because unfortunately the flight attendants will not be able to retrieve that. You're going to have to carry it on your person, and it will be able to pass through security, but you'll have to let them know that you are diabetic so that you have it on hand. Make sure if you're traveling, especially if you're out of the country, that you have enough medication on hand, depending on how long you're going to be gone. Have a backup, vial of insulin. Have enough syringes. Because you don't really know what the availability of some of this equipment is, especially if you're out of the country. And sometimes it's a little bit difficult for physicians to call in prescriptions, especially if you're, in a foreign country. Okay, they don't always have the same kind of equipment, and you want to be familiar with what you're using and not let things like this ruin your vacation. Make sure it's kept cool. Make sure you continue to provide aseptic technique with your medications. Follow the same rules you would. But I think the big thing is to make sure you have it with you, and that you have, a simple carbohydrate on board in case you would start to feel hypoglycemic, and then to make sure that you have enough of the medication and all the necessary equipment that you need. Okay? And I would suggest too, teaching patients that if they do have a pump, that they do have a backup of syringes and insulin, just in case while they're on vacation or wherever they're traveling to, that if that pump doesn't work correctly, that they always have another means in which they can provide themselves their insulin injections based on their glucose levels. Okay, so always important to know that. Okay, and this is a very old picture, very crude, very simple type of insulin pump. They're much more sophisticated now. We have a faculty member who is a type 1 diabetic, and she has such a nice pump. I think she said her pump was listed for about $2,500, but it really is quite an incredible device in which it beeps and alerts her if her blood sugars start to go outside that parameter that she sets, and she can also look at kind of a trend and how her blood glucoses have run. And some of these devices actually can be downloaded to the physician's office, so instead of bringing in a written journal of what your glucose has been, some of these results can be actually loaded to your physician's office, to his computer. So like I said, the incredible technology that now has gone along with some of these pumps, in which it really keeps your patients much safer to prevent those serious complications such as DKA. And this is just showing a pump. A is the pump to your right. B is the injection cannula. Okay. C is the glucose sensor, and D is the actual data transmitter. And as you can see, that area right there, B, is probably where her insulin needle is at. But you can see that for the most part they're rather small and compact. But if you want to go swimming or showering, obviously, I don't know how many of these are waterproof, you can disconnect it for a short time. But most of the time these are working 24/7. You normally should not disconnect them like at nighttime or anything like that. They should be on the person at all times because they really are monitoring the patient's blood sugar all the time. You only take them off for very short periods of time for any kind of short-term activities, and then be sure to remember to reconnect them again so that we can begin the monitoring process and hopefully the delivery of the insulin based on patient's carbohydrate intake. So again, patient education, I can't stress this enough, but of course we as nurses have to first understand how this equipment works. Now I know there are many different types of pumps out there and AccuCheck machines that we have to make sure that if our patients have any questions that they're using these devices properly. Insulin storage, teaching patients about refrigerating insulin, dose preparation, inspecting insulin for any changes. And even with people who use the pumps, making sure that their batteries are up to date and, they are definitely providing insulin to the pump, that it doesn't get too low. Making sure that along with the administration of insulin that they are definitely monitoring their blood glucose levels and really preventing any type of infection, because these are invasive devices along with the injections, sometimes 3 or 4 times a day. So you need to make sure that obviously washing your hands before giving yourself an injection, cleaning the site off good, waiting for the alcohol to dry, and really not sharing your AccuCheck machines with anybody, because things like hepatitis and some of your bloodborne pathogens can actually live outside those machines, and if you share them with somebody who has some kind of contamination or viruses or something like that, it could spread very, very easily, because those can stay alive for quite a while if they happen to get their own blood on your machine and then you use it and then touch the machine. So it's really not a good idea to share those kinds of machine with anybody. You should become very familiar with the equipment you're using, your pump, your syringes, your vials, making sure it's dated once it's been opened, inspecting the insulin itself. So there's quite a lot of stuff that we do all the time as nurses, but we have to explain this to our patients because they're not medical people and they don't understand it. So we have to keep them safe, because we sure don't want them getting some kind of infection due to the fact that they weren't properly taught how to give themselves an injection carefully. Infection control measures, as I just talked about, and of course along with diet therapy. Now most of these pumps will sense if someone has eaten, because remember, these pumps very much want to function like a real pancreas. So it senses when it eats, and that's when it delivers the insulin, just like our own pancreas does. It's just submitting or secreting a little bit of insulin when we're not eating, and then once we do eat, it will secrete a higher amount of insulin based on usually carbohydrates, and that will help bring those blood sugars down, just like our own pancreas does after we eat. So I can't stress the importance of you know, making sure that with insulin therapy, if we're giving individualized injections, maybe 3-4 times a day, that along with that insulin or those oral hypoglycemic medications, we are knowing each time what our patients or their own blood sugar is. So they should be, continuing to monitor their blood glucose levels, okay, to prevent any problems with hypo or hyperglycemia. Because sometimes things change, and sometimes medications need to be adjusted, especially if they're seeing a trend where, a few months ago my blood sugar was good, but all of a sudden I'm eating the same, but my blood sugars just are not coming down like they used to. So that's significant, and maybe it's time you call your physician, and you guys can, the patient and physician can talk about, what kind of changes need to be made to hopefully bring those glucose levels back down into the normal range. Okay. All right, this is a big topic, and we could spend an awful lot of time on this because if you really stop and think about it, this is probably one of the biggest challenges our patients who are diabetics have in regards to what do I eat? What do I do to keep my blood glucose under control? Because definitely what one eats, what is it they're trying to accomplish, especially your type 2s. Maybe initially, once they've been diagnosed as a type 2 diabetic, the goal between healthcare provider and patient is, I'm going to lose weight. And so that is something that needs to be talked over, with your physician, and then he could implement a dietitian into the picture to determine, how many calories a day you should be eating so that you, if you are planning to lose weight, that you're doing it in a very, very healthy way. And think about our patients who are diagnosed as diabetics who already have underlying chronic diseases, maybe already have cardiovascular disease, maybe have hypertension. Those things will definitely help to determine, what kind of nutrition, what kind of a diet would be best for you to follow, not only to keep your blood glucose under control, but really to slow down the progression of cardiovascular disease and to keep that blood pressure, obviously, within good control. So there's a lot of factors that will really influence what these patients, eat, okay? And this slide just kind of summarizes kind of a way in which we can kind of begin the teaching and the process of educating our patients of how to eat and how many calories to take in a day. All foods nowadays, according to the Food and Drug Administration, have labels, and this is where patients and even ourselves who want to stay healthy and eat healthy learn to read those labels to kind of get a sense of what those foods actually contain. If you look at food labels, and most of the diabetic diet is based on carbohydrate counting. It's much easier when food labels are available, and you can look at how much carbohydrate is in the food you want to eat and decide how much of the food you eat. And the two most important lines with these carbohydrate carving are the serving size and the total carbohydrate amount. So depending on how many calories you're taking, which will give you with each serving size, sometimes depending on if you're trying to gain weight or lose weight, you may have to eat a larger serving size or decrease a serving size depending on what your goal is with your particular dietary needs. And with those labels, a total carbohydrate on the label will include sugar, starches, and fibers. And if like I said, the patient's trying to lose weight, We'll look at the calories, and we'll compare products that can be helpful to find those lower in calories per serving, okay? And of course, to minimize or cut risk of heart disease and stroke, we might look at saturated or trans fats, because then we'll look for labels that have the lowest amount of saturated and trans fats per serving. And then, of course, sodium is a big factor too, because people with high blood pressure, we're going to look at sodium levels and look for foods with less sodium. So I think we go back to some of the information that we talked about with our cardiac diet, because obviously hypertension is a big risk factor for cardiovascular disease. And it can be a problem with later on kidney disease. So between being diabetic and having hypertension, those are two factors that we want to kind of eliminate or minimize to prevent any further deterioration of some of the other organs. And it's really important too when we're really talking about dietary control with our diabetic patients. I mean, some of these suggestions and advice on how to eat healthy when you're diabetic can also be used for people who are not diabetics. It's really important that as a diabetic, particularly when these patients need to have their blood glucose controlled by diet and medication, that they eat 3 meals a day and sometimes a snack at nighttime, depending how their blood glucoses are through the night, and are they going to wake up with the dawn phenomenon where their blood sugars are high. So it may take some juggling to hopefully kind of get these patients where we want them to get. And as I said, with any type of diet, no one is going to be ever perfect, okay? We're not perfect in our normal daily lives. We once in a while, eat a little bit too much, and holidays and special occasions tend to make us, probably eat more than we should, or drink more than we should, or have an intake of too much sugars or carbohydrates. So I think we have to be very kind to our patients and not be judgmental. And I think some of this information about diet control when you are a diabetic really needs to be given slowly and gradually, especially by someone who is of an expert, such as a dietitian. And I think it's really important that even if a patient's been a diabetic for a long time, that we kind of reevaluate what kind of a diet they follow, even if they've been a diabetic for 10 years. How's your diet? Do you have any questions? Did they ever learn about dietary control back when they were diagnosed 10 years ago, or have they just kind of been, kind of controlling it on their own without really not much education behind it? These are some of the principles of nutrition in diabetes. Protein should only be about 15 to 20% of total daily calories, especially if a person has normal kidney function. And we'll talk about why that is, because obviously the byproduct of protein is urea, and that's where we get, creatinine levels and things like that. Carbohydrates are about 45 to 65%, so you can see that it's much, much higher percentage of these types of food when they are diabetics. Include fruits, vegetables, whole grains, legumes, and low-fat milk. Dietary fat and cholesterol really depends on the kind of a patient we're talking about. Have they already been diagnosed with heart disease? Are they young? What's their family history like? Obviously, we all should practice some degree of fat and cholesterol control to prevent cardiovascular disease. 20% of which only 10% can be saturated. Those are the bad fats, along with all these trans fats. Fiber is good too. Fiber improves carbohydrate metabolism and really does lower cholesterol levels. And the American Diabetic Association encourages about 25 to 35 grams a day to help stabilize blood sugars. This can kind of be a lot sometimes in the beginning. It can cause your patients a little GI distress, sometimes diarrhea. So we can cut that down when we first start out with more fiber, and then gradually increase it as the person gets a little bit more accustomed to it. Plus, this helps to curb appetite a lot, especially if it's a person that we're trying to see lose weight. And usually the healthy way to lose weight, especially with many of our type 2s, because that's why probably they're diabetic, is about 1 to 2 pounds a week. That's kind of the healthy way to do it. In addition to these percentages of certain nutrients to take in as a diabetic, we look at that glycemic index. It's a term used to describe the rise in blood glucose levels after carbohydrate-containing food is consumed. Those should also be considered when a meal plan is formulated. And those are just foods that sometimes will increase glucose much quicker. And sometimes we want more of the complex carbohydrates, which kind of keep those blood glucoses more at an even keel. When we look at this exchange system, okay, usually that refers to 1 carbohydrate exchange for 15 grams of carbohydrates. And that kind of translates into 1 unit of regular insulin for each 15 grams of carbohydrates consumed. And nowadays, instead of the food pyramid, they use what they call the plate method, okay, which kind of separates certain nutrients, very similar to this percentage that I just talked about. So, as I said before, this is a really complex topic in regards to dietary control. We can also look at, diets for type 1 versus type 2. Somewhat a little bit different goal that each one of those patients want to achieve. A diet plan for a type 1 correlating eating patterns with their insulin, their onset, their peak, and the duration. Meals, their snacks, and insulin regimen should be based on lifestyle. You've got to think about the person who may work night shift. And don't forget, too, in regards to regular meals, snacks are also important in relation to the amount of timing, especially with exercise. And we'll get into that later on when we talk specifically about exercise. And remember, we have to respect some of the food routines or ethnic-related ways in which some of our cultures eat their food, availability of foods based on occupation, financial, religious, and ethnic constraints. That we don't want to say to the person who, is of Indian or Hispanic descent that they have to eliminate all those types of food. Maybe we can discuss modifications, okay, because we have to respect what they're used to eating, which is respectful in their particular culture and family. So maybe there's alternative ways in which we can offer suggestions in a way they can eat that food, but in a more healthier way, as long as they're continuing to, monitor their blood glucose levels and, really talk it over with even the person in their family who does the grocery shopping. Now, with our type 2s, many of them, that initial goal is to lose weight, okay? So we really encourage them to eat meals in equal size, about 4 to 5 hours apart, a couple snacks, but also, following a low fat and low cholesterol diet. So those are things that we want to, encourage with our type 2. So their goals with type 1 and type 2 is just a little bit different, okay? But the bottom line is, just like with us who are maybe non-diabetics, with nutrition, just as with a diabetic, ingesting proper vitamins and minerals meeting energy needs, achieving and maintaining a reasonable weight, and avoiding those fluctuations in blood glucose. And if it is a person that's a type 2 diabetic who very often has high lipid levels, low HDLs and high LDLs, we really want to get those down to reduce those risk of any macrovascular diseases, which would encompass some of your cardiovascular disease in the heart and in the peripheral disease too. Usually if someone is overweight, we usually decrease their calories between 500 and 1,000 a day, and that gives that safe goal of trying to lose 1 to 2 pounds a week. So those are things that, we really have to, talk about too with our patients, okay? And we just are trying to keep that blood glucose at an even keel, and like I said, to really avoid some of those very serious fluctuations or that problem with that real quick spike in blood glucose levels, okay? Here's some other things that we may want to consider when we talk about sweeteners, because maybe some of your diabetics may have questions about that. They're usually calorie-free. They're fine to eat. Some of our artificial sweeteners come in like diet pops. Only if your patient has acceptable glucose levels that we would encourage them to, not really encourage, but allow them to eat sweeteners. Alcohol is a big one, okay? Even though it's a carbohydrate, it does affect blood glucose, especially if you're drinking without eating, okay? It really can be a potential problem for a person developing hypoglycemia. Alcohol should always be ingested with or shortly after meals, and we substitute it for 2 fats. We count it as fat, exchanging when calculating caloric intake. Usually men can have 2 drinks a day and women 1. They have a little harder time metabolizing alcohol. The danger with alcohol is hypoglycemia, okay? But we count it as fats even though we know nutritional wise it is a carbohydrate, okay? So that's really important to teach our patients about that, and even if they go out for dinner or maybe go out for a drink with a friend, they really should be eating when they're drinking. That's what could get somebody into trouble. If they go have a drink and they haven't eaten in a while, the potential for hypoglycemic is very high, and that's what we don't want happening, okay? Sometimes with sweeteners, some of them like sorbitol can have like a laxative effect, so maybe you want to warn some of your patients, especially if they haven't eaten a lot of those or they eat more of those foods that have a lot of those artificial sweeteners. Those may cause your patients to have GI problems. Some of the more common types of foods that have carbohydrates are your grains, oatmeal, barley, breads, cereals, pastas and crackers, starchy vegetables like potatoes, peas and corn, fruits and juice, milk and yogurts, dried beans, some of your sodas, juice drinks, cakes, cookies, candy, and chips. Like I said, I think the good place to start is learning about how to read labels, food labels, and it kind of gives you an idea of how much carbohydrate is in that particular food within each serving size, okay? And when we talk about, 15 grams of carbohydrates, you might think, oh, sounds like a lot, but it really isn't. What that would be, as an example, would be just like one small piece of fresh fruit that kind of weighs approximately 4 ounces, or a half a cup of oatmeal, or 4 to 6 crackers, or even just a tablespoon of jam, jelly, sugar, or honey, or 6 chicken nuggets, or a cup of soup. So you can see these serving portions. I think that's what people really have to get used to, because sometimes, especially if one is trying to lose weight, they'll really be quite surprised about how little amount of food you do get with something like 15 grams of carbohydrates. And like I said, this is a really very complicated topic. Many people who begin to learn how to eat properly, control their blood glucose along with their medications. Handouts are always nice, or even a resource for people to be able to refer to in regards to, the exchange diet. But remember, there's so much that is entailed, because so much of what we do controls our blood glucose along with food, stress. Some of these diabetics are on medications, other medications that may affect blood glucose. So all these kind of getting them in sync with each other to keep blood glucoses at an even keel without all this fluctuation really can be a little bit difficult and challenging in the beginning, especially after the initial diagnosis. But I think what's important, some of the rules are to eat 3 meals a day, pretty evenly spaced apart. Obviously with your type 1, they're definitely on total insulin. So much of their diet is based on what kind of insulin they're on. Obviously, in the beginning, if a type 2 is trying to lose weight and they eventually reach their goal, they may make adjustments in their diet as well as in maybe their medications. They may not need medications at this point because they're less insulin resistant because they've lost weight, and that I talked about obesity being the one big factor that really increases insulin resistance. So with the loss of weight, that really helps the utilization of insulin much more. And maybe at that point, medication isn't needed anymore, okay? And that may continue for years and years and years, as long as that pancreas is still secreting a fair amount of insulin to keep blood sugars under control. And we talked about the exchange systems based on the 3 food groups: carbohydrates, meats, and fats, and carbohydrate counting. And like I said, they use more of the food plate rather than the food pyramid. That's kind of an obsolete principle. They felt that the food plate works a lot better. It's easier for people to visualize how much of that plate should have carbs, fruits, vegetables, and things like that. So I think it makes a lot more sense. Your fruits are a small part. Your vegetables and your protein and grains are probably the bigger portion of that plate, as it makes sense from the percentages we just talked about from that one slide. And obviously, how much you eat too is based on your ideal body weight and how much exercise and how sedentary or how active you are. You multiply your ideal body weight times 10, and then you factor in your activity level. Are you sedentary, moderately active, or very active? And say, for instance, if you're a young adult who's 150 pounds, you, depending on your activity level, you can have an additional 450 calories, along with 1,500 calories, and that would give you a total of almost 2,000 calories a day. And if you were trying to lose weight, you would decrease that by 10%, which would be you know, almost a little under, about a little less than 200 calories, about 195 calories less a day. So that's kind of a good formula to use when trying to determine how many calories a day you should have. But again, it's not all about calories. It really is important to read food labels, watch the serving size, and determine how many carbohydrates. And depending on your own health history, should you be watching fat, should you be watching sodium, okay? And hyperinsulinemia is chronic high blood insulin levels that occur with intense treatment schedules and result in weight gain. These patients may need to treat hyperglycemia by restricting calories rather than increasing insulin. And the insulin that you guys use that you're more familiar with are the U100 insulin along with a U100 syringe, because your insulin should always match your syringe. But there is U500 out there, and that is more of a concentrated insulin, because maybe these patients were not getting their blood sugars down, so we have to give them more insulin. And anybody who's taking over 200 units of insulin a day would probably go to the more concentrated U500 insulin, because then you don't have to give as much insulin because the insulin is much more concentrated. So in order to treat this hyperglycemia, instead of giving more insulin, they would restrict calories, trying to get these patients to hopefully lose weight, because sometimes it's due to the fact that they might be extremely heavy, making them more insulin resistant, okay? So getting regular exercise, and then if they develop hypoglycemia, that we're not giving them a lot of carbs or sugars to get their blood glucose up, and then we have to give them insulin to get it back down. So that's kind of what hyperinsulinemia refers to, okay? And some of our patients can be very resistant to the insulin that we give them because not everybody reacts to medications, as I've said 100 times before in all our previous systems. You know, we have to see how our patient responds to the medications we put them on. That's why it's so important to really be aware of any hyper or hypoglycemic manifestations that may occur, and that's why we as nurses need to know them as well as our patients. All right, I'm going to stop there, and then I will start another lecture on exercise. Thank you.